Welcome back to Rural Health Today. This episode is another installment in our season on maternal care and rural health, where we're talking with maternal health experts about rural maternal morbidity, genetics, mental health, and more to understand the barriers to proper maternal health care in rural America. Welcome. I'm excited to introduce our guest today, Dr. Amanda P. Williams, Interim Chief Medical Officer at the March of Dimes. Now, we've all heard about the March of Dimes. You know, we've heard commercials, we've seen television shows where certain sponsorships, and certainly we know of the broader overview about what the March of Dimes does and the work that you're engaged in as an organization. But, you know, Dr. Williams, first of all, welcome to the podcast. It's great to have you here. And for our listeners who may not know you, could you share just a little bit about your role at the March of Dimes? How long have you been there, and really what brought you to this position?
Sure. Well, thank you so much for this opportunity. It's super excited to be with you and your big audience impacting rural health. So I've been at the March of Dimes since last summer, and really it is an organization where almost all of the work I've done across my career comes to fruition. Yeah. I am a practicing OBGYN.
Very good.
Taking care of thousands of patients over the years in Northern California, primarily inside of the Kaiser Permanente healthcare system. I went up through the ranks over 17 years in women's health leadership, at which time I had oversight of the entire outpatient maternity journey.
Wow.
Left in about 2022. I don't know if I saved my life or lost my mind. The jury perhaps is still out, but I knew I was making a big impact inside of Kaiser, but I wanted to make an even broader one. So I started working with the California Maternal Quality Care Collaborative, which is our country's largest perinatal care collaborative that brings hospitals together to work on issues of maternal morbidity and mortality. It's based at Stanford University, where I'm also on the adjunct faculty, and one of our projects was funded through March of Dimes. And that kind of brought me back to March of Dimes, where I had been a volunteer. When my son was born, my first son, I myself had preeclampsia with severe features. He was born preterm. He was in the neonatal intensive care unit. And despite being the chief resident at University of California, San Francisco, one of the best programs in the whole country, I too got preeclampsia and had a NICU baby. Wow. So we became volunteers, and then it came full circle when this opportunity arose to start splitting my time between March of Dimes and CMQCC at Stanford. So it has been a very full circle and wonderful journey to be at March of Dimes, where we work on preventing maternal and infant morbidity, mortality, and preterm birth, and all through a health equity lens, because we know that where you live, what you look like, what language you speak, actually do have an impact on the care that you are being given. So it is a privilege to be able to lead this work at March of Dimes.
Wow. I think on that note, we can close in prayer and this interview's done. What a remarkable, I tell you, it's a remarkable introduction. I don't think anyone has ever been able to summarize the content of our entire interview in an introduction, and you did a marvelous job, because all of the things that you've just spoken about are issues that you have passion and purpose to pursue. And this is so exciting that we actually get this time with you. So thank you for sharing your journey and how you got there. What a remarkable career, a provider, and then not only providing services at the bedside, but then having a greater vision and impacting tens, I guarantee you say thousands, tens of thousands of lives at Kaiser, and obviously being a role model that we know you are. And congratulations on your very successful journey. It's very exciting. So I stand and sit in awe of the work you've done and of your background. And maybe there's someone listening today, Dr. Williams, who doesn't know you that well. We always love to do this. It's just, what's a fun fact about you? I mean, it could be something, and relate maybe to our audience about, are you a real person? Because, it sounds like you're pretty important, person right now. And so, how can you relate? Is there a fun fact we can get to know you a little bit better?
Well, I'll tell you that I am a bit of a fitness junkie. I
Nice.
was a Division I track athlete in college.
Amazing.
And have 8 varsity letters from Harvard
Wow.
in track and field.
Oh, my Lord and mercy.
And actually qualified for Olympic trials my senior year. And then I was very short-sighted. I actually declined the invitation because I wanted to go to med school. Now, what a silly decision. I should have deferred med school and tried to get onto the Olympic team.
You could be on a Wheaties box,
Exactly. So that was maybe a questionable choice.
I don't think so.
On my end.
Yeah.
But I decided to go straight into medicine instead of pursuing my
That's
Olympic dreams.
Wow, that is incredible. What a journey. That's amazing. Well, congratulations on those accomplishments. I was a water boy, if that means anything. It's the extent of my exercise. Well, Dr. Williams, it's a pleasure to have you on the podcast today. We're going to really jump into something right now that's very dear and very near to my heart. My wife is a OBGYN leader, and she's a clinical, was a former chief nursing officer, and she spent all of her time in OB really working with an important population in our community. And as you know, in rural communities like Hillsdale across this country, populations that are comprised of highly Medicaid, population for reimbursement, and, challenges with, prenatal care and then post-delivery and some other challenges that we have. And so I often look at this as, this is my mission field. This is her mission field. For such a time as this, God has called us into this opportunity. But, what we want to talk about today is something that I have taken a very strong stance for, which is to keep our, maternal programs, to keep our OBGYN programs, and to keep our OB unit open. And this is in a time in our country where many hospitals are folding their OB programs. The cost of delivering those in communities where the reimbursement doesn't cover the expense, i.e. Medicaid populations, it is a lot of work. It's a community benefit. And we've spent a tremendous amount of our time engaged in that activity. So today, what we're going to talk about is maternal health care from a medical perspective. And that perspective is really looking at this issue from your perspective and your lens as a physician. And families in rural America often have access to much less resources and to less help and individuals that are there to help their growing families. And that's just simply because of the environment that we're in. So I'm excited that you're here to share your perspective and insight as, you've done this OB work for a very long time, gynecologist, chief medical officer, and I think one of the most important titles, mom. And, you've experienced that, right? And hopefully someday even a greater title of grandmom, because I'm going to tell you, that's fun. That's really fun. That's really fun. But, Dr. Williams, you have obviously seen barriers to care. And when we talk about barriers to care, the impact of the Medicaid cuts that we're hearing now being proposed by Congress and the Energy Department, postpartum health, medical technology, and of course, all of those things. The question is, what does it have to do with rural health in America? What does it have to do with, maternal health care? And so I guess my first question I'm going to throw at you is, when did you first notice challenges and barriers in the maternal health field? And I would just love to hear your personal story of, what first interested you in addressing these barriers, because you obviously tackled them with purpose and with passion.
Well, first of all, I don't know if this is a coincidence or not, that you keep saying purpose and passion, and that's sort of my tagline.
Oh, wow.
So much so that for my 50th birthday, my partner made a poster that said purpose and passion.
Is that right? No, I had no, I had no knowledge.
I said, did he see me on some social media?
I didn't. But I could
But
sense it. I could sense it.
anyway,
I could.
it is. This is my work. It is my story. It is my passion. Because I truly do not believe that where you live, what do you look like, what language you speak, who you love, should make an impact on the care that you are given. And yet we know that this is the case, and this is particularly the case in rural America. Where there are so many hospitals closing their maternity care services and maternity care deserts.
Yes.
So if you don't mind, I'm going to take a moment to define what a maternity care desert
Please do.
is.
Please.
So that is a county level designation. So a county within your state where there is no obstetrician, no midwife, no family practice doc that does obstetrics, no licensed birth center, and no hospital with a maternity unit. So basically, nobody to oversee the birth and no location that is licensed for it. And it is 2025 in the United States of America. It is a shame and disgrace that 35%, over a third of all the counties in the United States are maternity care deserts. This is not okay. You know, a young couple does not, get married, try to buy a house,
Right.
find a neighborhood with a good school. They shouldn't be thinking about, will my wife have a place to have a baby?
Right.
That isn't a thought that happens. And yet they probably should, because a third of all counties are maternity care deserts.
Right.
And we know that families who live in maternity care deserts have to drive 2.6 times as far. So that's 260% longer times to get to the hospital than if you don't live in a maternity care desert. And for those of us who've been in obstetrics for a long time, you know that minutes matter in obstetrics.
Absolutely.
Babies do not come 9 to 5, Monday to Friday.
Rarely do they.
That's just right. That's just not how it works. And sometimes labor can escalate really quickly. And the last thing you want is to be on the side of the highway. God forbid you're having twins.
That's right.
Or you have a placenta previa or some kind of complication of pregnancy. This can really be life or death for moms and babies.
Absolutely.
So we have to take this maternity care deserts issue and hospital closures issue very seriously.
I absolutely agree with you. And, let's take that a little step further. So, we know these deserts exist, right? And I'm not going to get into the subject, but we want to, again, alert our listeners across the country that if the Medicaid cuts happen as proposed by both the Senate and the House in their reconciliation process, you're going to see greater number of those deserts occurring in our country. We've got to be a voice for the voiceless. We have to speak up. I would encourage you, I'm just dropping this message in today. I'm encouraging you to contact your congressional leaders and explain to them why it is so important to keep Medicaid funding available, specifically as it relates to rural communities just like yours here in Hillsdale and throughout this country, because these are important opportunities for us to rise up for this time, to be a voice for the voiceless. So I just dropped that message in, but I think what's important.
Can I double click on that a little bit, JJ, if you don't mind?
Please do.
Because Medicaid is my sort of number one topic of advocacy at this moment.
Yeah.
So a couple things. First of all, some people don't realize that they're getting insured through Medicaid they are.
They are.
So in California, we call it Medi-Cal, or in Oklahoma, you call it Sooner Care, or Husky Care in Connecticut.
Yeah. Michigan, healthy kids. Yeah.
Right. And they're not realizing that that's actually public Medicaid insurance.
Right.
And over 40% of all births in this country are insured through Medicaid.
Right.
We had our advocacy day on the Hill in March, and our CEO asked a congressman, I will not disclose what state he was from, but what do you know, Congressman, what the percentage of Medicaid births are in your county? And he said, I would guess, I don't know, you guys are the experts, around 20-25%. And she said, Congressman, that number is 75% in your district.
My God.
And so we've got to make sure that our legislators know
That's right.
this really impacts people. So there's the Medicaid for individual insurance. And so that's what gives you the ability to go to your prenatal care visits, go to your postpartum visits, for your kids to get their checkups, to get their vaccines, their well child checks. And then there's also Medicaid that reimburses the hospitals.
Yes, that is correct.
And especially in rural counties, we have an even higher proportion of hospitals that have the majority of their budget through Medicaid and Medicare.
Absolutely.
And so we've got to protect the people and protect the hospitals.
Amen. Now listen.
I didn't need to go too deep, but I really care about this.
No, we're going to have a revival here, okay? Because I'm telling you, short of an offering, I'm ready to preach it, because I'm telling you right now, this is the most pivotal point, I believe, in our time. And I know that there's issues that have arisen in the past, whether it's nurse staffing ratios or whatever that have, but this is an issue that I'm passionate about, that I think all of us CEOs in hospitals, we call ourselves a mid-sized vital access hospital. We're not as big as a system, but we're not as small as a community. At the end of the day, it doesn't matter the size. We have to advocate to keep and restore our Medicaid program for those in need. Here's why. Because if we have this belief that this is only going to impact Medicaid patients, then the enemy has won. Because let me tell you something, when I shut down my obstetrics because we cannot run it, because there is no reimbursement from Medicaid at levels that would even come close to even community benefit, it impacts everyone in those respective communities. No one has access to obstetrical care. We have witnessed this throughout the country. When hospitals close their OBs down, it's not just closing them down for Medicaid patients. You're closing them down for every patient. And when there's an abruption and you have a lack of ambulances and medical personnel that can even transport the EMS crisis in this country, patients are at risk, and I'm telling you, up to and including death in some cases. And this is not just saying that we're going through a campaign of scare tactics. This is a reality of what we face in rural America today. The nearest tertiary center is an hour away, and the nearest OB delivery is going to be an hour away if these hospitals closes, or greater. And that means in communities without public transportation or transportation barriers, period, that child is being delivered in homes, back seats, and it's very, very dangerous, as well as consideration of the prenatal care that our moms need and that families need to take care of themselves and their babies. And so this is a far greater issue than just saying, oh, it's only going to impact the Medicaid population. It impacts everyone. And so I want to be a voice going even outside of OB and talking about how it impacts our seniors, who get a secondary benefit from Medicaid if they're on Medicare. The list goes on and on. But we must speak up today, because Congress is going to be assembling on the Hill in a week, and they're going to make decisions that will impact us for centuries. And I'm not being dramatic.
Absolutely.
There's no way to claw back.
I would say that, March of Dimes has a very strong advocacy branch. We have both marches, meetings at state legislatures, of course, in Washington, D.C., on the Hill. And then we've got our grassroots advocates also. So if you go to marchofdimes.org, you can sign up to be one of our grassroots advocates. And if there's something that's coming through your state legislature that impacts maternal or infant health, you can be alerted. We give you templates to write to your legislators.
Beautiful.
We give you the telephone numbers to make calls, because people care when they hear from their constituents.
That's right.
It really matters.
It does.
And so I heard you say voice for the voiceless. Our marginalized communities actually have voices, but they're not being listened to.
That's right.
So it's not that they don't have a voice, it's that their voices aren't heard. And we, as March of Dimes, can help amplify your voice.
Absolutely.
By us working together as a team.
That's right. And when we lift our voices together, it is really advocating for everyone. When we lift our voice as leaders and we go against the norms of the day, we can impact lives, and we've witnessed this. We're talking about something very serious. If you've just tuned in, something very serious right now across this country, and that is the proposed Medicaid cuts that would impact our children. It would impact our seniors, and ultimately have devastating impact to the point where Scott Becker, who was on this podcast a few weeks ago, talked about 800 hospital closures that will occur as a result of this across this country. And these are much needed places for patients to receive care, for moms, for deliveries, for dads, for communities to come together during critical crisis times in their lives. This is a place where we need to be delivering that care. And so if there is no opportunity to do that because Congress removes the funding, we have a serious problem in our country that's going to lead to even more terrible outcomes. So that's just a preamble, folks. You're now tuning into the actual interview here with Dr. Williams. That just got us started. So obviously we're passionate about certain things, and I think we have a similar passion on a few things. I really want you to give a sense to our listeners of what you, on the front lines and working in the leadership roles that you have and currently where you are now at March of Dimes, what are you seeing in maternal health care right now, both good and bad? And, can you share your perspective of maternity of maternity health in rural communities? What your perspective is working with those communities?
So I'll say that my perspective is informed both by data and personal experience taking care of patients and through my leadership roles. And I did have the privilege of serving as a member of the Pregnancy Associated Mortality Review Committee for the state of California. So we actually go and look through the records of all the moms who lost their lives during pregnancy and that first year afterwards. And that was a really impactful experience.
Absolutely.
And we'd get, scores of pages of documents from these deaths. And yet, at a certain point, I realized if I saw the cause of death and I saw the zip code or the county that woman was living in, there was no stronger predictor of what was going to happen to her than that county. So, for example, if I saw ectopic pregnancy and I saw that she lived in a rural county, I knew she was going to die. And that just breaks my heart. Because our patients need systems to be in place to serve rural America, to be able to keep them safe.
That's right.
We already, overall in the United States, have the highest maternal and infant mortality than any other of our economic peer countries. So, for example, in the United States, it's fantastic to see that maternal mortality is starting to come down from the peak where it was during the pandemic. But we're still at 17 deaths per 100,000 live births. Compared to a place like England, that number is 5. Like, we're not even close.
Not even close.
Compared to a place like Sweden, that number is 2.
Yeah.
So, and we have 1 in 10 babies born too soon, being born preterm. So the state of U.S. maternal infant health is dismal to begin with. And then if you put all of these different cuts, especially around Medicaid, into place, we're going to be going from bad to worse.
That's right.
Now, the good news is that on the last CDC report that's coming out of these maternal mortality reviews, over 80% of the births were preventable.
Yeah.
So we know what to do. We know these perinatal quality collaboratives. We know if we had better EMS systems in place, if we keep our rural hospitals open, our safety net access hospitals open, that we can make a difference. But there are so many systemic problems that are undermining the health of our moms and babies.
Right. Yeah, absolutely. I guess for our listener, Dr. Williams, who's today thinking, all right, so what does all this really have to do with a March of Dimes? And As an organization, can you really just tell us about how the March of Dimes assesses the state of maternal health and, how you approach solutions from an organizational perspective for healthcare organizations, for communities, and for families? Just give us that, thumbnail. How does it all come together?
Sure. So our mission is to eliminate preventable maternal and infant death and complications in preterm birth and make sure that it's done through a health equity lens. One of our pillars is around data. And so we are big data aggregators. We take information from the CDC, from the NIH, from HRSA, the Health Resources Services Administration, and bring that data together to create reports that tell us what is going on in specific states and sometimes in specific counties around preterm birth rates, maternal and infant deaths, C-sections. We bring all this data together, which is part of the reason why it's so important that we stand up against some of the cuts that are being done in these health and human services agencies.
Yes.
Because, and JJ, I want to emphasize this, you cannot solve a problem you don't understand.
No, not at all.
And so we have to be able to segment data. We have to be able to say, what does it look like for the Medicaid population versus the commercial insurance population, rural hospitals versus urban hospitals, different ethnicities, different races. If we're going to be good stewards of our dollars, if we are going to be strategic in our approach, we have to be able to understand the problem. And so that is what March of Dimes does, is that we take all that data and bring it together to have a deeper understanding so that we can partner with different state agencies, nonprofits, community-based organizations to help put programming and policies in place that are going to target these drivers of maternal and infant death.
Yeah, absolutely. And this is going to be me plugging, and it's not part of our script, but I do want to highlight it because a majority of the work that you do, it's not as if you have an abundant amount of funding coming from the government. You rely on, the contributions and the charity of many Americans who make contributions. And I really want to just highlight, and I'm not asking you to do that, I'm going to do it, but I would just highlight the opportunity that the community has across this country to donate to the March of Dimes for programs like these. And I cannot stress the importance of financially supporting this program and the importance of this program to help stabilize our rural communities. So, that was me. That was not you. That was my plug. And
thank you. I appreciate it. I appreciate it because we are run on 90%. Over 90% private dollars.
Yes, you are.
So we're very lucky because a lot of our partner organizations are losing tons of grants.
Yes,
they're losing federal funding.
Yeah.
But we are not. So it's an incredibly important moment for March of Dimes to step up. But we can't do that without donors like your audience.
That's right. Absolutely.
And if you don't mind, I'd like to sort of emphasize what are the types of things we do. We talked about our advocacy work.
Yeah.
So my 4 action verbs: we advocate, we innovate, we educate, and we collaborate. So we talked about advocacy. Our number one area of advocacy is around Medicaid right now.
Right.
But we also advocate for things like paid family leave, for doula access, for reviews of maternal and infant mortality cases. So advocacy is very important to us. We also do a ton of education, and we do education. You can go on marchofdimes.org if you're pregnant, you're planning for pregnancy, your daughter's pregnant, or postpartum. We have patient-facing education, but we also have birth worker and nurse facing education for clinicians. We do lots of NICU family support. So people who've had pregnancy complications, baby in the NICU, we try to do preeclampsia, preterm birth prevention education. Education is a huge part of March of Dimes.
Mm-hmm.
We also innovate, and that's where our history is. So many people associate March of Dimes with polio and the polio vaccine from FDR. We have our 5 prematurity research centers where we're trying to do team science and really collaborate to get answers around why preterm birth happens. We give out research awards to investigators. And let me tell you, with the cuts in funding to NIH and CDC, the number of investigators who are desperate for their research funding, we can't make the future better if we're not funding research.
Right.
And March of Dimes is doing that.
Yes,
we also invest in companies, small startup companies that have promising interventions. So one is called Novikov. It's to see if we can seal up leaks of amniotic fluid if you break your bag of water too early. One called Seven Starling brings depression screening through telehealth to more remote areas, and hopefully we'll talk about telehealth a little bit more because that's one of the interventions that we can leverage in rural communities. And then we collaborate. We actually have baby mobile health centers, which are these giant purple buses that have clinics inside of them. And we actually go out into communities, a lot of them rural. We have them on indigenous land as well, to bring the care to patients. And we do that in partnership with healthcare center, different health plan partners, or we set up inside of your NICU, inside of your neonatal intensive care unit, to bring our NICU family support systems to those locations. So if you want to impact the maternal infant health ecosystem, there's no place better than to do it with March of Dimes.
Absolutely. Concur. 100%. I would encourage our listeners. Absolutely. I would encourage our listeners to go to the March of Dimes website. You can make a contribution directly on their site. The types of programs and the impact is phenomenal. And, speaking of programs, you touched on just a little bit about technology. And what is the role that technology can play in maternal health care outcomes for rural communities? Can you talk a little bit more about that? Because you have some great innovations occurring there.
Yeah, I mean, we learned a lot during the pandemic. We all acquired gray hair as well, but we learned a lot about what can be accomplished through telehealth.
That's right.
People got more used to getting their care using telehealth, especially if it's video and you can actually have interaction with the provider. Now, there are some limitations, especially in rural communities, around Wi-Fi, around bandwidth issues. But it's important to know where the places in your community where you can get free Wi-Fi, whether that's at the local library or at a retail location like a Starbucks or a McDonald's. There are places that one can get telehealth even if they don't have Wi-Fi in the home. And what that does is allow expanded access to providers. That's especially important for the ultra high risk doctors. So like maternal fetal medicine doctors are almost exclusively in big medical centers, which are mostly in the urban areas, but there are telehealth programs that can expand that. It's further important for mental health. People highly underestimate the impact of mental health, of substance use disorders, around the time of pregnancy and postpartum. If you are counting them, it is actually the number one cause of maternal death in the postpartum period is mental health and substance use disorders. And we have a huge shortage across this country.
We do.
With mental health providers. And that's particularly key for people who have perinatal specialization in mental health.
Mm-hmm.
And so if you're using telehealth, you can then expand the access to those types of providers, which is why we're invested in companies like Seven Starling that does that. We're also partner with a company called Mama that brings mental health screening and referrals into neonatal intensive care units. So these types of partnerships are very important for us to be able to get this sort of care out into more rural communities.
Absolutely, and you're doing a phenomenal job with it. And part of our, as we look at this series that we're engaged in, very robust discussion has already occurred around, mental health services or even the lack thereof in rural communities for moms. And so this is something that I'm passionate about as well, that we make sure that we have access points for that population. But with that, and I know that we've kind of beat the issue of Medicaid up a little bit. I could spend probably a few days on it, honestly. But, if there's anything else, that you want to bring to our attention regarding how these Medicaid cuts will in fact impact the quality of care for moms and babies, I would love to hear, just your elevator speech about that, about what these impacts are going to look like if that does come true.
So many of our patients are getting their care through Medicaid. And one little language tweak that I encourage people to do, nobody says, oh, that grandma is on Medicare, right? She's getting her insurance through Medicare. But people say, oh, she's on Medicaid. And that brings sort of a derogatory attitude towards it. So, but if we say she gets her insurance through Medicaid or through Sooner Care or whatever it is, I think that sort of just starts shifting the perspective.
Mm-hmm.
Many folks don't know that over 95% of people who are insured through Medicaid work. This is not lazy folks sitting around waiting for the government to take care of their health care.
Right.
These are folks who are low income, often have multiple jobs that don't provide insurance for them. And so it's very important that they have the ability to be able to get care.
Mm-hmm.
So that might be a mom who all of a sudden finds out that she has twins and she works as a childcare provider and is driving the bus for the county, but now can no longer be a county bus driver.
Correct.
Because she's pregnant with twins. And now she has to get her insurance through Medicaid. If there are not enough providers who will accept Medicaid as her insurance, here she is with this high-risk pregnancy, and yet she's not able to get care. Then if the hospital closes that's in her county, which was the safety net hospital that can't afford to keep their doors open because they won't get reimbursed, especially for a high-risk patient, then she's more likely to have complications. So I think bringing in real-world examples and helping shift the narrative around who is insured through Medicaid and what Medicaid does to support our communities, I think goes a long way. So again, I would encourage your listeners to sign up to be advocates with the March of Dimes so that you have some templated letters, telephone call scripts that you can reach out to your congresspeople to let them know that if you hurt Medicaid, you are hurting moms and babes across this country, regardless of whether they are individually insured through Medicaid or not.
That's right. And many of resources, as just indicated by Dr. Williams, there's the March of Dimes. The American Hospital Association has a great system on their website, which you can link up with and also have template letters. And then as a board member of the Michigan Hospital Association, I can share with you the robust system that we have in place where all you have to do is if you live in Michigan, put in your zip code. It'll pre-populate who your congressional leaders are. It'll pre-populate a letter. All you have to do is sign that letter and it goes right to their inbox. I would encourage you to engage in those type of activities to let your voice be heard. Very disappointed. And I think there needs to be a great awakening. And I'll stop there. With an understanding of who is impacted the most by Medicaid. And I want you to understand one thing, and this is a disappointment of my party because this is my party, and they're off base here on all these issues because, they want to distract with the conversation of saying that it's 27-year-olds home playing video games. That's not even close to any representation. What frustrates me the most is the faces of Medicaid are the people we go to church with. It's people at our family reunions. It's people that we see in the grocery store. It's people that we worship with. It's people in our own places of employment where they're underinsured and where they have a family of 3 or 4 and they need that extra insurance. It's the individuals who are working hard at the gas station, under 50 employees who don't have to provide health insurance, and they're working 40 to 50 hours a week to try to make it with 3 children at home. These are the faces of Medicaid. The faces of Medicaid isn't that 27-year-old. And it grinds me to think about on the backs of all of these people, we're going to be taking a very small, very minute population of individuals, and on the backs of all those who need it the most, we're going to try to make reform. That is so irresponsible. So I want to encourage you, if you're listening today, understand that your voice must be lifted up. And when you lift your voice up, you're lifting all of our voices up. So, all right, let's get into our time has escaped us. I think you and I are on the same page about all of these issues. But, one of the areas that we still need to tackle in our podcast today is postpartum care. And it's really an important part of our journey. And so I guess what advice, and maybe it's best advice, you can give to mothers who live in rural communities who may not have access and the same number of resources as urban populations. Now, we're fortunate, Hilsa. We have, 3 OBGYNs, we have pediatrician, we've got, several midwives, APPs that work for us. We're blessed with a beautiful obstetrics unit. But at the end of the day, not all of those resources, and we have mental health services, this, a 10-bed psych unit, the list goes on, but we're rare. We're a rare community that has those things. So for those communities that are listening right now, individuals where those are not available, where there's a lack of resources for programming and for postpartum care and those type of things, what would you say is the best advice for moms of where they can go? Where can they look? How do they get to those places, Dr. William?
So the first thing I would say is prepare for postpartum during pregnancy. Because once that baby is out and you've got, breast milk everywhere and you're exhausted and you're not sleeping and, that is, you might be recovering from a C-section. That is not the time to start planning. So to educate yourself ahead of time, it is always easier to cancel appointments than to make a new appointment.
That's true.
So if you have any history at all of any mental health, anxiety, depression, OCD, anything at all, make an appointment for yourself 3 to 4 weeks after your due date. Also, schedule your postpartum visit follow-up appointment with your OB, your midwife, nurse practitioner. Schedule that before you go in for delivery. Mm-hmm. Have an emergency contacts list so that your family knows who to call in case you have anything go, sideways in the immediate postpartum period. And then if it is available in your area to register with a doula. So more and more, and we hope this does not get cut, insurances, including Medicaid,
yes,
are covering doula care.
They are. And
people often focus on doula care for the birth, but doula care is vital for postpartum.
Sure is.
Having had to cancel the postpartum part's the hardest part, not the actual birth itself. And then finally, blood pressure. So blood pressure is known as the silent killer. And people might have heard of preeclampsia, which is a severe pregnancy complication that can happen actually in the early postpartum period also. So your daughter, niece, neighbor does not need one more bouncy seat or frilly dress. Register them for a blood pressure cuff.
Isn't that amazing?
And make sure that you are checking the blood pressure on a daily basis for those first couple of weeks, if not month postpartum, to make sure that you can pick it up, because oftentimes by the time folks get symptoms, it's too late. And then lastly, just listen. Mm-hmm. Please listen to postpartum women. We live in a country where the voices of women are not listened to in the same way, especially if it's young women, women of color, women with low educational or income levels. But oftentimes patients are telling us, I have a headache. I don't feel right. My chest is hurting. If we say, oh, honey, just take a nap. You had a new baby. Oh, sweetheart, you're fine. That's not going to save lives. We have to listen to these young women and make sure that they are getting the care that they need. One of my colleagues, Dr. Allison Stubbe, is a postpartum researcher, uses the candy analogy. So, when you're pregnant, it's like having one of those fancy Christmas bonbons that are like round with the fancy foil and plastic on it.
Oh, yeah.
And everyone's like, oh, the bonbon, the bonbon. And then you take the bonbon out, the baby comes out, and then they throw the wrapper in the trash. Women are more than discarded candy wrappers. They deserve to be cared and listened to and loved on in that postpartum period. And so please do not throw out the candy wrapper when the candy comes out.
Wow. Dr. Amanda P. Williams, interim CMO at March of Dimes, inspirational, visionary, passionate. We thank you so much for joining us today on this podcast that highlights the challenges and the opportunities for rural communities throughout this country. And I want to thank you for joining us on this important episode of Rural Health Today as we are beginning to wrap up our series on this issue. And I would just like to thank you for the work that you're doing and the work that March of Dimes is doing on a daily basis. And it's incredible work. Continue your purpose and your passion. You're doing it for all the right reasons. You're not doing it just to be, heard individually, but you're doing it to lift up other voices. And I want to thank you for that. So thank you for joining us today. And before we close, we do like to wrap up with one segment. It's called the Rural Health Recommendations. And for every guest that we have on our program, we'll ask them to contribute a recommendation on rural health and healthcare. Now, it could be a tip for someone new working in rural healthcare, or maybe some sage advice on thriving in a rural setting and the challenges that you've experienced or that some of your colleagues have experienced in rural health. And then I add these recommendations to our online guide, and that's available on our website. And it's very, very useful. They find it at ruralhealthtoday.com, and we've heard much feedback about just the individuality of recommendations that impact individuals' lives because they read about a recommendation that they can take and improve their community. So I'm going to leave it there and say, Dr. Williams, what is your rural health recommendation for someone listening today? What can they do?
So my rural health recommendation from the patient perspective is to educate yourself, to do your homework ahead of time, come to trusted resources like marchofdimes.org to figure out what might be in store for you with pregnancy and postpartum, because it does not always happen like it looks in the movies. Yeah, and then from a provider perspective, to constantly ask yourself, what is getting in the way? What are the barriers that my patient is facing that might be getting in the way of her getting the very best care? So whether that is her transportation, her insurance, the information being given in the language that she speaks, we have to constantly ask ourselves, what is getting in the way from especially a systematic standpoint for patients to get the care that they really need and deserve.
Wow. Thank you. This has been powerful today. I'm so grateful for your time, and I know you have a very busy schedule. It's been great to have you on the podcast today, Dr. Williams. Continue to do the work that you're doing and shed the light that you're shining in many, many areas of our rural communities. And thank you very much. And thank you to our listeners for tuning in to Rural Health Today. Catch our next segment, Rural Health News, to stay up to date on the current state of rural health every Monday, wherever you get your podcasts. Don't forget to check out our latest updates and resources from Rural Health Today at ruralhealthtoday.com. And make sure you subscribe to the show so you never miss an episode. Until next time, stay safe, stay healthy, and stay Hillsdale strong.
Thank you for listening to another episode of Rural Health Today, the podcast where we connect you to what really matters in rural health. Rural Health Today is a production of Hillsdale Hospital in Hillsdale, Michigan, and a member of the Health Podcast Network. Our host is JJ Hodshire, our producer is Kirsten Newlon, and our audio engineer is Kenji Ulmer. Special thanks to our guests for sharing their expertise on the show, and also to the Hillsdale Hospital marketing team. If you want to submit a question for us to answer on the podcast or learn more about Rural Health Today, visit ruralhealthtoday.com.